Now we'll talk about some more bacteria, starting with Viridans streptococcus. We'll talk about the characteristics of Viridans streptococcus. So what are some examples of Viridans strep? We have a whole classification variety of these bacteria, but there are a couple that we want to know for sure that are very high yield. First is Strep mutans, next is Strep sanguinis, and the next is Strep mitis. So Strep mutans and Strep mitis are found inside the oral cavity and can cause dental caries, and Strep sanguinis can cause endocarditis and problems with the heart. So they're all normal oropharyngeal flora. All three of these can be found in the oropharynx, and certain ones can cause dental caries and cavities and plaque. Others live in the oropharynx but can cause other problems, such as endocarditis. So they can cause dental plaques and cavities, and they're resistant to opticin. That's how you differentiate them from Streptococcus pneumoniae. So dental plaque and cavities, and these are the examples. They're normally found in the mouth, so all of us have them. I know, pretty gross, huh? We have a bunch of bacteria living in our mouths, but hey, that's life. They get subacute bacterial endocarditis. What does subacute mean? Subacute, as opposed to acute, means that you have a week to month-long progression of the symptoms of endocarditis. So you get a low-grade fever, you have chills, you have valve problems, but they're very, very low-grade and take a long time to develop. And because these bacteria are not very virulent, they usually affect previously damaged valves, such as rheumatic fever or congenital heart disease or previous surgery or prosthetic valves. So this is the reason why endocarditis prophylaxis is needed for dental procedures if certain criteria are met, because these bacteria affect damaged valves. And we talked about endocarditis prophylaxis on a previous slide in the pediatrics section. So like we said before, it presents with weeks of low-grade symptoms. Alright, so it takes weeks to maybe months, while acute endocarditis takes days to a week. So what are some classic signs of endocarditis? The ones that we always hear about, but they're not super common, but they are things that should immediately make you recognize, hey, this patient might have endocarditis. First one is Janeway lesions. So what are these? These are red macules. Remember, a macule is a non-raised, small red area, and it's non-tender on the palms and soles. So it's like you have spots on your palms and soles that are red colored. That's a Janeway lesion. Roth spots. What is a Roth spot? It's a retinal hemorrhage due to a septic embolus going into the eye with a white center. So you see this red area with a white center? That's a septic embolus being stuck inside of the eye, the retinal vessels. Next, you get septic emboli. If you have a right-sided endocarditis, you get pulmonic emboli, because that's where the blood's going to go. Or you get a systemic emboli if it's a left-sided heart endocarditis. It's going to spread into the systemic vasculature and cause all kinds of problems. Next, we have Osler nodes. What are Osler nodes? Osler nodes are painful elevated nodes on the hands and feet. So they're large nodes on the hands and feet that are painful and red, as opposed to Janeway lesions, which are flat and not painful. These are elevated and painful. This is all you need to know about Viridans streptococcus. Now we'll talk about some more bacteria that finish off the Streptococcus group, Enterococcus and Streptococcus bovis. So Enterococcus classification, we have two different types. We have E. faecalis and E. faecium. And these, when they infect certain hospitalized and immunocompromised patients, can be very, very severe. So they're normal colonic flora. They're found in your colon, but they're very, very resistant. And they can even be resistant to vancomycin, which is very, very dangerous for our patients in the hospital. So why is it so resistant, and why does it cause so many problems? Biofilm helps. Remember, biofilm protects you and allows you to adhere to certain surfaces to colonize. And it also can get vancomycin-resistant Enterococcus, causing severe nosocomial infections. Nosocomial means getting it from the hospital. So you get severe infections from Enterococcus in the hospital. So what are some diseases now caused by Enterococcus? Because it has biofilm, it can attach to the urinary tract and cause a UTI, especially after urinary tract procedures like putting a catheter in or putting a scope or some kind of instrumentation. And the way you treat it, if it's vancomycin resistant, nitrofurantoin. So this works even if they're vancomycin resistant for a UTI. Bacteremia, this is especially important with femoral catheters. Remember, femoral catheters have a high risk of infection, and the reason why is because of bacteremia, maybe from Enterococcus. So you diagnose this with a blood culture, and you also have biliary tract infections or abdominal abscesses that you can get from Enterococcus as well. Remember, Enterococcus is normally found inside the GI tract, so it can go towards the biliary tract or even cause an abscess in the abdomen. And how are you going to diagnose this? If you have a biliary tract problem, you always use an ultrasound. Ultrasound is the best initial test for biliary tract problems, and for abscesses, a CT characterizes it the best. So treat with antibiotics and incise and drain it if it's an abscess. So if it's a biliary tract infection, antibiotics should be enough. But if it's incision and drainage is needed if there's an abscess, because antibiotics cannot penetrate the wall of the abscess. So you need to give incision and drainage to open up the abscess, and then antibiotics to cover the bacteria that have leaked out. So what are some medications that work against Enterococcus? These are going to be piperacillin tazobactam or imipenem. Imipenem is a very powerful carbapenem that's used, and piperacillin tazobactam is a penicillin with a clavulanic acid inhibitor. And these are very good against Enterococcus because it's a gram-positive and it's beta-lactamase, and this will cover it. Imipenem is a very strong carbapenem that's pretty resistant to beta-lactamase, and these will be able to take care of your Enterococcus problem. Another thing you want to know is subacute bacterial endocarditis, especially after GI and GU procedures. Especially if they have a GI or GU infection, you can seed the blood with the bacteria once they leave the GI and GU tracts, and the Enterococcus that escapes can go to the heart and cause a subacute bacterial endocarditis. And a thing to know is that ampicillin and gentamicin work very synergistically and improve each other's activity against Enterococcus. So if you have bacterial endocarditis caused by Enterococcus, ampicillin and gentamicin is your best bet to treat it. And if it's vancomycin resistant, what are you going to do? Linezolid or daptomycin. So those are going to be useful if they're vancomycin resistant because they don't have the same mechanism of action but are still as powerful. So now Streptococcus bovis. So this one you have to know for one important reason. It's got a subtype, Galolyticus, and this is associated with bacteremia and a subacute endocarditis in patients with underlying colon cancer. So if a patient has colon cancer and they have a bacteremia with Strep Galolyticus, you should always think of underlying colon cancer. And how are you going to diagnose that? Right, with a colonoscopy. So if you have a patient with subacute endocarditis and bacteremia, growing Strep bovis, suspect colon cancer and order a colonoscopy. Very, very important.